And I have 11 o'clock Eastern, so we'll go ahead and get started for today. I want to welcome you to the Flex Quality Networking Council meeting for the Medicare Beneficiary Quality Improvement Project, supported by the State Office of Rural Health. Just want to thank Allie Orwood with IRHA for hosting the Zoom platform and appreciate her assistance, and Joyce Fillenworth and David Conrad, the State Office of Rural Health. Today we're going to talk about current recovery processes and emergency preparedness plans after a pandemic, much like COVID-19. We're very honored to have with us the home health team, Lesa Schlatman. Lisa's going to be presenting first. She has earned an Associate of Applied Science, Nursing Associate degree, and a Bachelor's of Science in Nursing. She has a really strong background, particularly in care coordination processes, population health strategies, and process and quality improvement initiatives. Lisa spoke with us about a year ago at one of our CAH convening meetings and just did a fantastic job there, so just wanted to welcome her back, as well as Kerry Dunning. Most of you are familiar with Kerry. She has been working with us now for a couple of years on the Swingbed quality benchmarking initiative, and just want to welcome her with us today. She has tons of experience with this work in the post-acute arena, and just is a wealth of knowledge in a lot of different areas. We do encourage you to chat in your questions today in the chat. And also, you're more than welcome to unmute your line if you would like to. We do ask, and Allie will be helping facilitate keeping the background noise down as much as possible, but you can unmute if you go over to the participant column and unmute the little microphone next to your name, and you'll be able to answer questions directly. So with that, we will go ahead and get started. And Lesa, I will turn it over to you.
Thank you so much, Becky, and welcome everybody. Good morning. We have a ton of information to cover today, so I may talk a little quickly because I know Kerry has a ton, I have a ton, but we really just want to provide you with as much information that we could kind of collect around this COVID topic and kind of the different things that we can do moving forward, and currently, you know, how we're trying to recover and decide what our next steps are. So I'm really going to kind of cover recognizing the importance of the key care transition components and talking about that, how you kind of follow patients during these kind of pandemics so that in the future you can be prepared, how to engage families and patients to maintain that quality outcomes, because I know there were some issues with that. So we're going to talk about that. I'm definitely going to go over some infection control approaches and how to, again, improve kind of your efficiencies with that and the approaches so you can maintain that constant contact with your patients and not have them scared to come into your facilities. And it'll be kind of embedded with some financial approaches here and there, as well as on Kerry's when she does hers as well. Anyway, Becky already introduced me, so I won't go through that glorious little piece of information there. I will get started on, so in your area in Indiana and COVID-19, you guys are currently following your 5-stage reopen plan. I'm sure you're aware of that. Your fully open target is July 4th. If you're not aware, then great, I'm giving you information. You're going to be required, though, to continue screening, testing, and there has to be tracing efforts. So from a healthcare perspective, that's important. There's going to be businesses have to develop internal policies to kind of address those COVID safety plans. That's all businesses, and that will be from the healthcare sector. We're not quite sure some of those answers yet, but we will be enforcing social distancing. Face coverings are recommended. So you do have a nice, down at the bottom, I'll put a lot of links throughout my presentations. So this particular information you can go to by clicking that link on the bottom, and it really does outline, according to what business you're going to, or what place you're going to be frequenting, kind of what the restrictions are going to be for that area. So it's a really nice, you guys in Indiana did a really good job outlining those 4 stages. And you'll be required to screen employees daily. So, but from a healthcare system, they're going to require that all symptomatic, who's yours there in your area, have to be screened, that everybody has to be tested. So we're not going to allow this anymore where we have tests, we don't have tests. There is going to have to be a process implemented where everybody's tested, especially your first responders and medical staff. And then you have to have a process to notify all individuals who test positive because they're requiring that contact tracing for all positive cases. Now they'll assist you in that. They have some things they put in place, and I'll get to that in a second. But moving forward, your state has implemented over 180 testing locations. Now that's pretty important to understand because it's not just up to you. They've also implemented some other areas so that your ability to test all of your population should be pretty good at this point. You have a lot of spaces put up. And as far as the tracing, they have utilized a centralized reporting process, and maybe you're aware of that already. So positive cases will receive a text, email, or they'll have a call completed with them. And they have your contact tracer group that they've hired. Now they've only hired 325, but they plan on hiring a total of 500. And I don't know who's aware of this already, or maybe you're very aware of it, but I think that's amazing that your state has gone to that step to hire these contact tracers, and they're gonna help with that contact tracing. And that's huge. So if I'd really like to know if I've come into contact with someone, that's been a huge conversation we've been having. How do I know if I walk by somebody or a family member or somebody that lives down the road that I may accidentally talk to? So how do you know? Anyway, you guys have this process, internal process, centralized process for reporting. Those contact tracers will help complete all of that. And then they will help perform those follow-up activities, like getting them, potential treatment, or if they have to have things put up in place. Now, as far as PPE, because that's been the hot topic, it's never really stopped, but for businesses, there is a marketplace, and you can go out to that link, and it does help with the PPE. And there's going to be future funds for healthcare. It's under discussion, though, as we know, so we'll see how that kind of turns out. But I know that our efforts moving forward are going to be a lot different, so that the next time hopefully we don't have a surge, but if we do, we should be sitting better. Now, just some fun statistics. How long does COVID live on surfaces? So, this has been all over the place. When we first started talking about it, it was, hardly could be passed from person to person. It didn't involve your pets. Now it involves lots of pets. And so what they have found is this is kind of the standard list now. It can live for up to 5 days on metal, 4 days on woods, up to 2 to 3 days on plastics, up to 2 to 3 days on stainless steel. Cardboard, that's kind of the scary part because we get all these packages up to 24 hours, but Miss Kerry Dunning definitely has a great process where she leaves a lot of things out on her porch before she brings them in the home. Copper, which copper is supposed to kill everything, but it can live up to 4 hours on copper. Glass up to 5 days. It's detectable in the air for up to 3 hours. So I think this is a huge concern for us as we set up our areas for treatment, as we have patients commingle, as we start to move forward, as we fly. Flying again, I'm a little scared to get on an airplane because what does that mean? We had a very prominent doctor on the Today Show ended up infected, and he thinks it went in through his eyes. So I think some new conversations are going to be happening around that. And shoes are a huge topic, guys. There were some ICU staff that tested positive for that nucleic acid from the virus that was on it. Not real sure if that particular acid is going to cause the infection, but it just shows you that they can find remnants of this everywhere. So if you are cleaning, now I don't know if there's questions that are popping up because I see quite a few things, but Becky, are you going to help with those as we move forward? Because if I keep clicking that open, I'll probably.
Yes, I will. People are just signing in to let us know that they're on.
Okay, good. I didn't want to miss somebody's question. And so infection control, when you're cleaning and disinfecting, this has been a huge conversation as well. What do we use? What's going to kill everything? It's not just bleach products. It's not always the safest choice. So the EPA, if you go out to this website, they have list N. It's updated consistently. And the things that are listed on list N are safe for you to use for COVID cleaning because it will kill it. But I need to remind you, you have to check the registration number on the product because the names differ. So you may have a component in your cleaner that does work, but because you're not seeing your name on there, you may not think that it's safe to use. So you have to look at the registration numbers because again, on the list, sometimes they'll list that it's for different organisms, but if it's on list N, it's for COVID. They just list the worst case scenario of what it can kill. So if it's worse than COVID, it's listed. But again, if it's on list N, you can use it to clean your N95 masks, So I won't go into great detail, but here's just some links for you guys, because again, a lot of discussions and confusion around these N95 versus other masks and the shortages, which ones to use, can we extend the use or not? How do we decontaminate those? Because that has become a huge practice we noticed out in New York. And if we start having to do that in our areas, we need to understand what does that mean and how do we do that properly? And when to use what type of mask, because again, do we always have to have on the N95s? Do we not always have to have masks on, when to and when not to? So all of those are there for your convenience when you have time to go out to those. So that way you can kind of figure out for your facility and your settings, what makes sense and what does not. Because, you know, we had a lot of healthcare facilities that really kind of blew through their supplies and really didn't have to have those N95 masks on all the time. So you have to understand and be vigilant about when are they needed, when are they necessary, and that's when you should have them on. So again, on the personal protective equipment, if they are a suspected or known infection, you really need to get on your gloves, your gown, eye protection. We've learned that now, that eye protection, we've definitely been talking about it, but I think it's more prominent now that if those droplets can kind of just circulate in the air and come in through the eye and infect someone, because that's a probability now, although it's not yet proven, that we need to be careful about that. And N95 mask or higher. Again, this is for suspected or known infection. General masks for your patients coming in through the door. Designated clean versus dirty areas for PPE on and off. We talked about this a lot. A lot of the cross-contamination that's happening is because you're not familiar with the gear, how to take it on, and or how to put it on, how to take it off effectively without kind of cross-contaminating yourself. These are important components to understand, because that's a make or break of what's going to happen to keep your staff safe. So you need to practice, and there are some links down here that talks about how to put them on properly, how to take them off properly, and then strategies to kind of optimize that personal protective gear. And please go through with your staff. You need to set aside a time where just have somebody do a demonstration and have everybody practice. Just use, you know, a typical gown if everybody's happy, or if you've got a lot of social distancing happening, then I guess use disposable. But go through, put them on, put them off. You should really, a lot of people in facilities lost that true contamination because they had a clean and dirty area that was utilized for both. And if you're trying to put on something clean and you're touching the dirty area around you, then you're not doing any good. So I stress that you really have to kind of mark them off. It gets confusing. It's nervous. Maybe you haven't had to deal with a lot of patients and they come into your area and then we start to get nervous. So designate them, put a sign up, put tape on the floor, whatever you have to do so everybody's very aware this is the clean area. These are the clean supplies. This is where you take everything off, and then this is the process to decontaminate yourself before you move out into the other areas. So just some tips. Identify all potential services, even the less common ones. So this is kind of where we forget, we do all the common things, you know, we mark off or wash off the counters, you know, and handles, and different things. But, you know, the building entrance door handles, again, I had a huge conversation about this. If somebody's out in their car, coughing in their hands, haven't put their mask on yet, and they're coming in, their hands are now dirty, and they're touching that front door handle. And you have somebody else coming in that isn't infected, but they're touching that door handle where you first enter the facility on the outside of the building. Those are areas too that you need to do things. And I'll talk about that in a second. You know, the front desk, the pens, do we keep pens up there? Do we keep wiping each one of them off, or do we just give them little disposable pens and say, keep it? I mean, those are important conversations moving forward even. You know, people are sick. We think it's our internal germs. We don't worry about it as much, but we're touching everything. And if we're not one that's careful about containing our own germs, we can really spread them on a lot of things. Those credit card machines and things that they have to poke. We see that happening at Walmart. I love how they put the little plastic cover over them that never really gets removed. So we're all touching that same protective covering that really is protecting the credit card machine from us, but not really each other. So I think do what makes sense. Remove all waste more frequently, because people cough, use Kleenex, they throw things down. don't let that accumulate, especially if you have children that come into your areas, get that waste out of there, put them in receptacles that are not easily touched. Hand sanitizer, they recommend at least the 60% or higher. Have that at all entrances, guys, and sign for use. Remind people here, use this on your hands before you come in. Disinfectant wipes for those doorways that I just talked about outside the building. Put a handle and say, please grab this and open this door with this, or wipe it off, and then have a receptacle there to throw it away. Continue your waiting room social distancing, especially as we move forward. Chairs, partitions, what does that look like? We focus on the interior and forget about, our common used items. Things can get transferred inside the facility pretty easy. So signage to stop and call for assistance on entrance. I think this is a fabulous idea. So that if somebody's not sure and they've just kind of trying to do a walk-in or they have questions, have that sign on the door that reminds them, hey, please stop, call this number, go back to your car, call for assistance, and then we will assist you from there so that you're not cross-contaminating people. And again, for more information, the links are always at the bottom of if I have one for you.
Lisa?
Yes.
We do have one question in chat. Do you recommend some be the observer to ensure that staff members is donning the PPE properly?
I would create a checklist based off of what the CDC is teaching you, because it's a lot to read through. We know that it's important to read all those words, but even as an employee that's trying to protect themselves, they're not going to want to read through. So I would create a checklist, and if you need to, competency everybody on them so that they can't come back and say that they were not taught the proper use for that, I would almost recommend that. I would include that in your competencies. We do a lot of that fit testing with our mask. Why not competency them on how to not contaminate themselves? So that's a great question. I would definitely observe and maybe do some kind of check off. Okay, create disinfection plans and policies and align those with your emergency preparedness plan. You should have, because this is going to be a huge focus, guys. There's a lot of survey teams running around now that are looking at all of these plans, especially, the poor nursing homes have really been hit hard and they're scrutinizing, but they're going to come through these hospitals, especially ones that started to have a lot of numbers. I don't know what the fallout as we move forward. I haven't heard a lot of things, but then there's been a lot of families that are disgruntled because they don't feel systems were prepared, they were handled correctly. So it's very important, get your policies in place and make sure those make sense. And don't just do a blanket policy for everyone. I mean, your disinfection policy should really kind of clearly outline, how do we disinfect totally? And then how do we disinfect after patients? How do we disinfect in the different service lines so that it does make sense and pertains to those areas? Because again, when your survey teams come through, you want to show them that you definitely have concrete plans in place that should help protect your population and your staff. We want to protect our patients, but we want to protect the very necessary staff that's taking care of them. Track everyone in and out of rooms and anybody that you've had contact with. So it's important because of the tracing factor, but we also want to know if we finally have a positive patient and we had a certain handful of staff in and out, who was that? So to kind of limit that ability to infect somebody, you should have identified treatment staff. Do not cross them over. Do not have them, I say clean and dirty, and I don't mean it that way, but infected or potentially infected versus, someone just coming in for a well check or medication refills. And if they're still there, you've got to have kind of separated treatment staff so that you don't accidentally cross over. I recommend that you have clothes and shoes at your workplace. If you have the ability to do that, some systems do laundry there. That's great. If you have the ability to do that, I recommend that. Please leave your clothes, your shoes at your workplace. I thought I heard someone talking. Do not bring personal equipment into the rooms. So if you have your own stethoscopes, thermometers, things that you keep in your pockets, you cannot do that. And moving forward, I'm going to tell you, this is probably not a process that you should follow. Because anything that gets touched or contaminated, coughed on, and you're putting it in your pockets, even though we think we're careful and we wipe them off, I would say everything needs to be in the rooms and not walking around with them in your pockets. Limit the time in the room with the COVID-19 patients. So we talk all the time. So now we're kind of counterproductive to the things we're talking about, because we tell everybody at the bedside, please do all your charting. during these times, if you have a highly infectious patient, I would say get everything done that you have to. And then if you're able to come outside of the room to finish charting, again, you have to follow whatever policies your healthcare facility puts in place. And if they're going to mandate that you do it that way, you're going to have to. But if you have the ability to limit your time in that room, I would definitely narrow it down. Because as you hear, the healthcare staff that are becoming deathly sick or passing away from their COVID infections, it's really that loading dose of that exposure to the COVID-19 that really kind of played a part in how sick they became. So if you can limit that exposure time, it will definitely, if you happen to get sick, hopefully it will not be at that level. Visual alert signs at exits, just reminding people cover your cough, all that stuff, wash your hands, utilize protective gear, whatever. So that way it just reminds the patients and people coming and going that they need to do these things. If you go out to that link, there are things you can print off from there. So you don't have to create them. You can print them from there and utilize them. And I would say laminate them. I think I talk about that somewhere. Tracking also in and out of the rooms, again, helps with backtracking in case of the exposure. I just want to definitely compound on that if you aren't trying to keep kind of a tracking list of who's going in this room at what time and what staff have been actually in that room, I don't know how you can, if you're going to have some kind of sign-in, assigned rooms so that people aren't going in and out of other rooms. So that way, if you do have to figure out what staff potentially may have to go home and be isolated, it's a lot easier than just assuming that the whole entire staff was contaminated. Minimize surfaces that can become infected, guys. So remove all community items. I suggest this in the future. I know that we want to keep people entertained and stuff out in the waiting room, but get rid of the magazines, the books, the brochures, the toys. That stuff needs to go. We're at a point where we're finally realizing we just can't have this stuff sitting around because things live on it. Everybody touches them. Plus, I'm going to talk about a few things that you really want to try to get people in and out at a way that they won't need these things. Wipeable chairs, not cloth, or reduce the numbers of chairs that you have out there so that you need to be able to clean these surfaces. And I've been in a lot of waiting rooms that have cloth, and I know that you can spray stuff on them, but I'd say if you can have wipeable covers on your chairs, I would do that. Endless options for everything. That's trash cans, soap dispensers, doors, whatever it needs to be. Try to get those handless options in there because then that limits the amount of things that everybody's touching. And remove sign-in type materials, clipboards. Again, been at offices or places where they tell you to come sign in. Please get rid of those. You're gonna have to have someone check them in and they can type it in on a computer. Again, we don't want people touching stuff that gets handed around and then you touch it. Then there's pens and clipboards and things. There's no way to really safely clean all of that stuff. Patients' rooms. Now this goes for clinics or hospital side. If there's drawers or cupboards and stuff in there, they should be locked anyway. I'm sorry, your patients get in there and they open stuff up and they look through them. They touch things. They say, oh, wow, could we use this at home? Not that I'm saying everybody does it, but a lot of patients do it. I catch my husband trying to do that if we go somewhere and I tell him, shut the cupboard and stay out of there. You're not 5. But lock them so there's no chance for them potentially touching something that you don't realize they touched because they're not going to tell you. Remove all countertop items. Again, unless it's something that's sealed shut and locked so they can't open it. But again, the more you have out on counters, the more you have to disinfect and wipe off. Get them off of there. Get them in the locked cupboards where they're safe. Laminated signs on the walls. Don't be using paper because, again, if they go over and happen to cough on your paper or if it's, I think we're going to find out it filters through the air and just kind of lands on things. Laminated's better. You can wipe them off if you need to. They don't become stained and things probably aren't going to stay on them as well. And again, private rooms in hospitals, it's pretty standard, but it's not because I have it in hospitals where they do have 2 beds in a room. So during all of these kinds of things, we have to have private rooms. I'd say moving forward, private rooms are a must. And during a pandemic of this sort, you really should try to identify a separate unit that would handle those patients and not have them intermingled. I know a lot of your hospitals were very good at this and they did kind of set up triage and had separate units to take care of those patients. But if that's not something that you did, you definitely need to have those conversations moving forward to figure out how you can definitely do that. Limit the space. So If you're a hospital, you have a lot of random chairs and benches throughout. I know it looks nice, but at this point, you're inviting people to kind of sit and cluster in different areas. Take those away. We want to control where the patients are kind of congregating, because those are areas that need a lot more thorough cleaning. So, limit your waiting spaces and take away those random chairs and benches. Outside, I wouldn't be as concerned because, again, this particular organism doesn't live very well in the sunlight, so you're probably safer out there moving forward, but who knows what's around the corner, what's coming next. So have triage areas, again, separate areas for the sick versus do not intermingle. This is hard in the ER, but it's a huge conversation, and we're going to go into ED more on our second presentation in July. So I'll kind of outline that a little bit more, but having triage areas that filter people differently so that, again, they aren't sitting there. Even if I know someone's infected and they have a face mask on, it still makes your patients nervous. And that's the kind of things that will keep them home. So if you're trying to engage them and keep them interactive, you have to make them feel safe. So you have to figure out, how do we do this? Alternate entrances for sick patients. So a lot of facilities, RHCs, would designate like a back door, and that they would instruct their patients that they were going to enter through that entrance, and they would set up things. So you're going to have to do some rearranging, but it makes sense. If you have that separate entrance with a designated room or two for those patients, and you really limit the amount of space they're going across, you can definitely make that work. Separate bathrooms, sick versus other. Again, because the cleaning, you're going to need to be cleaning everything anyway. But again, cross-contamination is the concern. Don't be allowing your staff to use those dirty areas as well. That's just for those patients coming in. Designated medical equipment that stays in those sick areas. Again, I said this before, don't be moving that around into other areas. It stays there, it gets cleaned there, it's designated to that sick area. And so looking at scheduling, so should we have sick clinics where the people that think they're suspecting that they're infected, you have a routine time where they're going to come in and really try to limit it to that. Maybe you have it before routine visits, maybe you have it after routine visits, maybe a couple times a day, but specifically so that the patients coming in during the well times know that the sick clinics are here. Sometimes at the end of the day is easier if you can, if it makes sense, because then you have to do that thorough cleaning, and it allows a lot of that spray that you use to sit on things overnight. Curbside testing and triage. You saw this all over the news, and it was very effective. People could pull up and do curbside testing, or if you have a tent outside of your facility. I think now and in the future, we really should adjust to some of these as the new norm. Curbside, it's as long as it's on your property and adjacent to your building, that's considered part of your property. So you really could set up things as you move forward, that if they have certain symptoms, I never did understand, everyone says they have the flu, and then we tell them to come in the office and sit around with all the normal people that are just there for a well visit, and how many people are we infecting through that process. So we really need to look at, how do we make this different as we go forward? The patients themselves.
And
so
Lesa?
Sure.
Lesa, we do have one question in chat, and this might be a good time to address it, but could you cover for employees, a number of hospitals are not taking temperatures, but asking screening questions or doing self-surveillance. Do you know what is mandatory versus individual hospital preference?
According to your stages in Indiana, to me, it looks like it's mandatory to be at least checking temperatures on everybody that comes to the door. So you would want to have screening areas at your doors for patients coming in, and then for staff, healthcare staff, it should be mandatory to be screening everyone. I think some places are even screening more than once per day, maybe at the beginning, at the end, because, we're not going to catch everybody. We know this because there's so many that don't show symptoms. But I think the fever is one that they do start to see a temperature difference. Keep in mind, though, if it's hot weather and people are overheated because of working, you're going to need to have them sit and get off some of that gear and then check them, because we don't want a false positive. We don't want to be sending, well, here, let's put it this way. We don't want staff to know that if they get themselves overheated and then they get checked with a higher temp, they get to go home for 14 days. We don't want that unnecessarily happening either, but then we don't want to unnecessarily send people home. So hopefully that answers that. As far as my understanding, because all the states are different with their stage plans, but healthcare wise, everybody should be screening their employees to make sure they don't have any symptoms.
And I can double check with the state to see if there's been any changes, and we'll send out an update with the recording for the session. So
yeah, on that link back
Thank you.
that where I talked about the stages, if they go out to that, it really does outline everything on there, and there should be no questions once you kind of review that. That should help with that. Okay, education for your patients. If we're trying to keep them engaged and keep them in, part of our process, we have to educate them. We have to be reaching out to them during all of this. I know a lot of it was very unnerving for us. Staff were scared. What's going to happen? What are we going to get sick? How are we going to take care of these patients? Your patients were doubly sick because, what I've learned over time is we have our medical background and things just seem to make sense to us, and then we never quite understand when patients don't understand some of the simplest medical things, but to them it's all very confusing. So if we're going to have them stay engaged and keep them, quality care that we want to provide for them during this, we have to educate them. We have to let them know expectations. So if they're going to keep appointments, procedures, or sick visits, what do we need them to do? What is expected of them? When do we want them to come in? When do we not? Outline processes to follow for all of these. Give them reassurance that, hey, your safety comes first. These are all the efforts that we're doing to keep your safety. Some facilities have been phenomenal at this, and then some have just really not did very much. They sent out maybe a paper that said, your safety is utmost importance to us, and just kind of reassured them, but didn't really kind of go into details. This is everything that we're doing. Because, you have to really explain to them why these new approaches are needed, why it's going to benefit them, and why it's important to still engage with them. We've had the telehealth has brought us a lot of opportunities to continue our face-to-face and some billing opportunities. I don't know what's going to happen. Kerry's going to go into telehealth more, but we don't know what's going to happen with that as we move forward. Compliance is achieved with transparency. So if your patients want to trust you, you have to be transparent with them. Just really educate them. Send out emails, mail them something, get your patient portal going. This is the perfect time to say, hey, I know you want to know answers to your questions. I know you want to see these things. You want to interact with us. Get them on that patient portal. This was a huge opportunity to enforce that. Reassure them that if you have clean spaces set up so that they can come, and that, if you have your clean versus sick clinics, they'll understand that, wow, okay, so these are other patients that are not showing symptoms or not potentially infected that I'm going to be able to somewhat interact with, or going through that same space. We need to learn from this. So, talk to your patients, ask them, how are they feeling? What's going on? What concerns do you have? What has affected them? What issues do they see? Because that's how you adjust the care. If you want them to come in and still maintain that quality interaction, you have to make them feel at ease. So again, their input is important. Other considerations. So I think these are huge things to consider, guys. Patients call ahead for screenings. Wear disposable covering over clothes as we move forward. Masks always versus complaints of symptoms. I mean, what are we going to do as we move forward? How do we keep patients safe? I mean, we can't live in fear, but we also have to understand, how do we adjust what we're doing so that we can not live in fear, but keep everybody safe? I think the call ahead screening is a huge opportunity. But our big concern going to that level is we have asymptomatic patients that we're dealing with. And we've seen that a lot. We have to have a process now that protects us both physically and financially, because we have to be able to bill for the care that we're providing. And this has really crippled some systems because they weren't able to bill for those typical screenings. A question with that is, will many of these systems survive if we have a second surge come through? I don't know the answer to that. We're hoping. We've done a lot of education. A lot of other places are doing education so that we can kind of equip you with some answers of how should you be addressing this and adjusting. So operational goals. It's really about standardizing all your processes surrounding this. Be prepared for what is next. You have to improve that patient experience. I know that we've just kind of been treading water to keep our head above water, but now it's about improve that patient experience so that you won't be hit hard by this, so you can keep your patient numbers and volumes coming through. Optimize your workflows, get rid of those inefficiencies. provide that effective education to your patients, use patient-centered approach, improve patient chance for success. We're going to reduce those negative outcomes and improve operational sustainment. We really need to understand, how do we continue business as usual? For things like our current COVID crisis, we have to work on our patient relationship. Part of the big fallout during all of this was patients feeling scared and unsure. So we have come a long way with patient-centered care, but we are not yet there. We still have a lot of work to do if we want our patients to partner with us. Because the overall feeling during this crisis is, it was kind of every man for himself. And that's unfortunate, because that's what we want to avoid. So you've got to build your continuum of care. And I'm going to hurry, guys, because I know Kerry's still got to go, and she has a lot of content too. So I'm talking a little fast, but again, if you have questions, just stop me. I'm not going to read everything, but building your continuum of care, an integrated collaborative system. I think if there is ever a time to improve workflow efficiencies, it is now. We are definitely seeing that our continuum of care was very important during all of this pandemic. Wait times require wait space. So you have to improve those efficiencies, because then this increases exposure time and options. So efficiencies, we have to pull together as a system and address those efficiencies, follow scheduled patterns. We are seeing the importance of building that strong continuum of care. Without healthcare partners, the quality of care we provide is littered with patient care gaps. We can't do it alone. We have definitely learned that during this pandemic. Bringing pharmacy into the picture, that big yellow square with pharmacy services, they can join in this process. And there's some symptoms that already use pharmacy at the bedside, but I think during this whole crisis, utilizing them also, reaching out, doing telehealth, calling patients, and being part of that process would definitely close some care gaps with patients, especially with all these weird medications being recommended, and how do you, what should you be taking, what should you not be taking? There was a lot of questions surrounding that. So that continuum of care and the patient-centered care. So what does the patient value or see as important? That's really what guides their clinical decisions. So during COVID, they just don't want to get sick. During normal times, they just don't really want to get sick or sicker. I mean, it hasn't changed. It's the same thing. I don't want to get sick. So provide care that meets all the needs of the patient at the time when it's needed. So the patient is our partner in their care. So we need to lead together with them. So patient-centered care is important here. Again, pulling into that quality and engagement, this is why it's important. Prevention and proactive solutions are key elements. Build communication, collaboration across your continuum of care, integration for each patient. Instead of losing patient contact, utilize that integration to meet the unique needs. Does your patient understand who your partners are outside of the clinic? Did you allow them to understand their other services and resources that were a part of your system? Or maybe you realize you don't really have a good continuum of care, and that is a goal for you to work on right now. Otherwise, if you felt very siloed during all of this, there's work. You definitely have work ahead of you. Mental health patients, guys, dealing with those, and we had, a brief conversation about where are they, what are we doing with them, So an option to think about moving forward is there's these peer support worker programs, and they're unique, and I actually think they're quite interesting. There's links down here that you can go out to those to find out more about them. But basically, it's a peer that has experienced mental health or substance abuse. They've gone through treatment. It's been successful. They then get some training, and then they are connected with patients who have current mental health or substance abuse disorders. It really does improve engagement in treatment and services. And if you utilize a program like this, you really could have had an outreach approach with that to maintain things. It maintains care coordination contact during these types of crises, and it can prevent losing track of this population. Because again, they're already nervous, and if they have any kind of schizophrenia or some kind of disorder, anxiety, this really probably compounded it for them. So having that peer-to-peer relationship can help you effectively deal with that patient population. The CHW model, I love this. I love CHWs. I think they're very beneficial. The payment on it's kind of scattered, but for the most part, it can be very cost effective. They could again be doing the outreach. Again, I'm not going to read all of these, but you can understand that there's approach to this, that you can set this up, partner with clinics to kind of complete that CCM and TCM, partner them with portable telehealth so that you can complete visits face-to-face. For patients that were confused, didn't understand telehealth, having that CHW go to the house and be able to still connect them would again improves your ability to bill for those services. Now, Medicaid in some states will pay for CHW models, but otherwise, the Medicaid and some of the insurances, they are very open to negotiations about these models and providing some kind of payment for them. So just because that contract says they don't cover it doesn't mean a phone call shouldn't be made to say, hey, our system wants to implement this kind of model. We want to talk about if you have any kind of payment structure for that. They are very open to that, and you'll be surprised what you might be able to come up with. Reimbursement. So financially, telehealth was a huge opportunity. If I'm not sure of the future payment, if they're going to leave a lot of this in place. I'm hoping they are, because I think they're going to see, wow, this really had some value. But telehealth, you should have partnered with your CCM and home visits. There was e-visits and check-ins as well that could have been utilized. I do know a lot of systems. It was very slow at the beginning because it was so confusing, but I know a lot of systems did grasp onto those. If you did not develop a CCM program, or if it was just kind of starting and didn't have a lot of numbers, this was the prime opportunity to enroll your patients because it's consistent reimbursement always. CCM could have, you probably could have enrolled another 100 patients in this program during this whole pandemic. It's money above and beyond routine visits. You can partner with your hospital and clinics to implement this. Mental health falls under it as well. So if the G0511 is your RHC code for CCM, but it also has a behavioral health for like major depression falls under that. Care coordination can close those care gaps, especially during this crisis time. So that's something, if you haven't developed CCM, I would definitely get the ball rolling, get your program going. Or if you're a hospital, partner with your clinics to get them enrolling in these kind of programs, because that was probably a game changer for a lot of systems. And then TCM, of course, following your patients after that hospitalization, especially ones that had infections, and partnering with hospital clinic partners for reimbursement with the telehealth. It all really created one continuum of care. So pathway to continuous quality, understand who is in your continuum of care, build an approach for integration. You have to have communication, collaboration always, guys. If there's patient care gaps, which partner is going to help you close those? I'm sure you realize you had a lot of them during this, and then you have to find a partner in the future that will help that care gap go away. Educate patients on partners and resources, practice patient-centered care, and implement those care coordination programs. Maintaining quality, guys, patient education, already talked about this. Explain your goal of quality and what that means, outline what they need to do to help reach that goal. It's not just you, it's them and you, so it's a team. Identify those processes. Tools, design and utilize a worksheet for calls on telehealth. So I talked about this a lot. If you're trying to maintain a quality conversation with your patient, and maybe they're not so good at the telehealth part, but you're doing the phone calls, you should have developed a worksheet that they can fill out prior to the call or prior to the telehealth so that you are asking key information. You want to explain to them what the worksheet is, that you need it filled out prior to each one of those interactions. And then on that can include, their scheduled dates and things that you need to make sure they answer or you want them to know. It's a lot more effective when they kind of have a roadmap to follow. So if you didn't utilize that or didn't have one in place, I'd suggest develop a worksheet that you can use with your patients. Education helps that patient understand truly, needs of what's going on. It helps them feel included during all of this with some control. Trust and security is important. Once the patients learn that they have that for you, their interaction is much better. CCM programs achieve all of this above, I'm going to plug for CCM. It really achieves all of this. If you have a CCM program and a care coordinator, it's going to bring in additional revenue, patient satisfaction. It can achieve all those quality initiatives that you have in place. So I'm almost done here. Sorry, Kerry. Maintaining quality ahead. What about call ahead rooming? Maybe this is our new norm, guys. We stop making people wait for an hour in a waiting room. They call and say, my appointment time is this, is everything on time? If it is, great. Come in a few minutes before, you'll be roomed within 5 minutes. Adjust ahead if needed or behind if needed. It really limits the exposure to others and illnesses. Sitting in that waiting room, I've worked for some doctors that were very good at patients becoming in and out, and I have others that back up. We can't do that anymore. As a team, we have to come together and talk about how do we keep the patient flow going. It's a huge opportunity for patient satisfaction as well, because how many times do you have a negative survey filled out because a patient had to wait in that waiting room for an hour, hour and a half? I know what you're thinking, it'll never work. But it's time to, again, start thinking outside that box because we have new standards. Our current standards and processes did not prepare us for what happened with COVID, and we have to be very, honest about that. This is the right time for, open-mindedness with patients. They are very open to change because they know that it's needed. So make this a new norm for you, and your patients will definitely adopt it. Pre-visit activity. So to help with that, guys, collect some information ahead of time, just as you would when you collect it during the rooming. You could do that by a call, a triage approach, somebody screens at the door. I don't know, whatever that would look like for you. But don't have them wait until they room to get a lot of that information. Get that out of the way. Again, it keeps them busy and then gets them into the room, and your workflows are going to be a lot better. And let's see, maintain patient contact. Again, this is just kind of a list of all those things we talked about, just a summary. I'm not going to go through each one. Maintain engagements. Again, those COVID patients have a follow-up plan with those frequent check-ins and e-visits. Did you communicate with families? I think one of the biggest problems I had with all of this was those poor families being told they could not be at the bedsides. I'm not sure who ultimately put their foot down with that and said that's a must. I think that was horrible. Patients are dying and they don't have their families at the bedside. Is that something we really have to accept, or is there a way around that? We really need to definitely put that question out in front of us. Enroll your patients in these CCM programs moving forward so that you can maintain engagement should this happen again. Partner with your home care CHW programs, telehealth once home. Your non-COVID patients, promote, enroll them in CCM programs as well, because this should make more sense to them now than ever. It can help them avoid contact, but maintains quality and meets needs. Involve your family and caregivers. Send out bi-monthly education. This was a huge opportunity to keep your patients updated, to provide them with education, emails, mailers, things out through the patient portal. The more you speak with your patients, the more involved they're going to maintain and be. Again, assure them their safety is first. So, things that lacking operational plan impact. If you did not have an operational plan, you're going to have inefficiencies and waste, interrupted workflows. A lot of confusion happened for those that did not have an operational plan. Non-compliant and unsafe workarounds were happening, delayed care, increased errors, financial loss. There's a lot of policy concerns with all of this as we move forward. Future considerations. We will need to stay current with vaccine efforts, guys. What is coming? What's going to be recommended? Who are you giving them to? Is it going to be required for staff? So you've got to have somebody that's monitoring that. Barriers at check-in areas between seating, et cetera. Is that something that we should implement? Should probably stay in use from now on? Maybe. Air filtration systems. How do we kind of try to keep that air as clean as possible? Screening the new norm at all times, screening technology. There are some facilities that did pay a little bit of money. It was cost effective, and I wish I could remember some of that information now, but I don't. But it screens patients as they come through and automatically screens their temperature by facial recognition, some kind of, it screens their forehead. I can't get into specifics with that. But I want to say it was only a couple $1,000s for that. And I think, is that something that makes it easier for you to maintain that screening? And practice pretend scenarios for staff education, because again, this just kind of got thrust on us and a lot of practice did not happen, but please go ahead and practice with your patients. How do we fix the future? Think about your frontline caregivers. There were a lot of ethical issues that were struggled with, especially those patients that had to die alone. Why was this okay, guys? Overwhelmed systems lost that humanity factor. I mean, you've seen it on the news, bodies were just being stacked out in carts, mass burying. A lot of staff were worried about, they had to choose who lived or died based on supplies, testing shortages, our own becoming sick and dying, a lot of suicide in that healthcare realm. Those are definitely conversations to have because we don't want these happening again. So with that, thank you for being patient. I'm sorry, we are going to run over because Kerry has a lot of great information too. There was just not enough time to get all of this information together, Becky, for your people. So those are my references, but I'm going to hand it over to Kerry, and I'm sure Becky will be happy to introduce her. Kerry, are you going to share your screen, or do you want me to just keep clicking the arrow?
You can go ahead and just plug the arrow so we can keep moving along. How's that?
Great.
So I think if you just run over to, looks like, let's start with slide 35 and we can move on a little quicker. And Becky, I think you already introduced me well enough, so I'm going to just move into it. So I want to talk about post-acute, and this goes hand in hand with a lot of things that Lesa just talked about, because I am a big proponent of the CCM process when we're looking at how we're discharging patients either to home health or even home alone, certainly when they're going through swing bed, skilled, other settings, other clinics. We've got to have some coordination of all this care, and that's been a huge patient gap, which Lesa just talked about. So from acute, you can see we have a variety of post-acute sort of settings we can go to, but the same if you have swing beds or if you have skilled facilities in your systems, or you partner with, or in your immediate market area, there's a way to grow all these out. But I want to talk today a little bit about some of the waivers, and the biggest one that has come through for skilled nursing came out on May 20th. I have the MLM Matters number there, so you can look it up, and Lesa, you can go to the next slide. But what it did was allow hospitals through their swing bed services to offer long-term care, and that is different than skilled nursing. Skilled and swing beds have always been comparable as far as the language and regulatory basics, but because there were a shortage of long-term care beds in certain areas, they did allow hospitals to use swing beds for long-term care, and they still are. This will be in place as long as the health emergency stays in place, and then it will be taken away. It's restrictive in an awful lot of ways. You have to be very, very careful. You have to have made sure that you have done your due diligence, that there are no long-term care beds anywhere in your market area, or even just beyond, stretching beyond your market area. But it is an option, and obviously it took a lot of work for CMS to put this together. So there are some areas, New York, California, Washington to some degree. We may be even the situation in my state, in the Miami area. So there'll be pockets of this that may be able to use it. You can go ahead, Lesa. The current waivers are still in place right now to get into skilled, a nursing facility, or your swing bed. They have waived the 3-day acute stay regulation, which means somebody has come into the hospital and after a day can go ahead and go to a post-acute setting, particularly to a skilled setting. Again, are there long-term care patients? You have that good faith to see if they've exhausted all their other options. For those of you that have critical access hospitals in your systems or partner with them, they waived the 96-hour rule, and they waived the 25-bed limit. We've had a number of critical access hospitals in hotspots go over the 25 beds, and certainly a number of them have been swing bed patients as they've taken them out of acute beds in the larger hospitals, excuse me, and tried to move them down through the system. For those that have PPS settings, either a swing bed that's in a PPS hospital or nursing homes, they have relieved some of the MDS time frame requirements. I would be careful there. You don't want your people getting too far behind. And the other thing you've got to remember is you have to have a completed MDS submitted to what they call a key system before you can bill. So the more the MDS time frames are relieved, the slower the billing will be. So that's an internal decision your buildings and your C-suite are going to have to consider. Physician visits can be done by telehealth. I will tell you that's increasingly important in the skilled nursing facilities. I have a number of clients across the country, and I now have my 7th medical director come up COVID positive. 2 of them are quite ill. The other 5 are actually doing resident visits via telehealth right now. And the value of that, it's good for the physicians to be involved, but the patients know that physician. They know his or her face and voice, and so there's some consistency in that care, even though it's done telephonically instead of in person. They will allow you now to transfer to another facility solely for cohorting. As you know, in the skilled world, there's an awful lot of regulations about discharging and patient awareness, where they're going to be taken and why. Right now, if we have to move patients because we either need more beds for COVID or we need to move somebody who's a non-COVID patient, we have that ability to do it. And then there's the expansion of location. There are nursing homes and there are swing bed programs across the country that are using conference rooms and other rooms. I have one that's using the dining room area right now, and they've set up, I guess, what I would call a mini Javits Center, which is the New York Center, where they came in and set up little portable rooms across a major area. Next one. All right, so we have really three, when we're talking about swing beds, we have three processes that we're looking at, three programming items that we're looking at right now. Some swing beds are taking all COVID patients. And I'll go back and go through this in a second. Some are taking all non-COVID, so that they're helping their larger hospital partners, or again, if you're in a system, you've been able to move non-COVID out if you have a high COVID population within your acute process to the post-acute setting, and some are taking both. So the first one is, if they're taking all COVID, you really want to make sure your swing beds are separate from acute, that you can distinctly distinguish, even if there are COVID patients in the acute beds, you want to be able to track these patients separately. And the other warning or suggestion, strong suggestion that has been put out by CMS, is you want the same staff working with those patients. So some have been assigning rooms, so they may be having nursing staff, RTs, so forth, assigned to 5 or 6 rooms. Same with equipment. When Lesa was talking about infection control, obviously all the equipment are huge areas where we have to be very careful so that they are separating them that way. The non-COVID, you have to follow your admissions criteria. You can't just take anyone now because it is a health emergency. You have admissions criteria, or you need to adjust your admissions criteria, and a survey team will look at that. The same for those that are taking COVID. You may have, I've got a couple of, I think 2 now, swing bed programs that are taking vent patients, and they weren't prior to this pandemic. So they had to adjust their admissions criteria. And then you have to contact your referring hospitals if you're a swing bed program or swing bed hospital to make sure the larger hospitals know what types of patients you're taking. Some have continued because they really are in rural areas and they are taking a hybrid. They have some COVID and they have some non-COVID patients. So I think this is common sense, but I'll say this is what the government has written. You must have a separation of those patients. And again, you must have dedicated staff. So if you have staff that's working just with the COVID patients and other staff that are working just with the non-COVID. I think one of the things that we're going to be looking at as we go forward will be a debrief on what we did. Why did we fall into taking all COVID, or why did we take non-COVID, or where did we make these decisions? Was it sort of a trickle down from larger hospitals and we didn't have time to think about it because all of us have been thrown into this? Really, in 2 weeks' time, we went from talking about it into full-blown action. We also need to set up some planned types of patients that are going to be admitted in the near future. Right now, we're not out of the COVID patients. We may have them reduced. I've got some states that have 0 COVID patients in the state right now, and others that still have hotspots. So that's very dependent on what's going on in your immediate area. But what are we going to do going forward? Are we going to now set up, as Lesa said, a lot of the hospitals in my area have a COVID unit where they have carved out a whole area in the hospital, and we'll continue to keep that as a COVID unit until we get the all clear, whether that may be 3 months, 6 months, 8 months, 18 months from now, whenever that occurs. And then the other thing, reminder, is you need to add or adjust to your pandemic section in your emergency preparedness plan. Swing beds and skilled nursing are being surveyed right now already. Those who've had difficulties, they're doing virtual surveys. I have one that's last week that was under a 4-day survey, and one this week that's under a 4-day survey. So please make sure your emergency preparedness plans are in place and updated. Next one, Lesa.
And Kerry,
All
this is Becky. A couple of questions that came
Sure.
in, and this is a good time to ask those. Is we have one hospital that this was emailed to me that they currently are not keeping COVID-19 patients in their hospital. If the patient meets testing criteria and needs to be hospitalized, we ship them to a higher level of care. So internally, do they need to test a Swingbed patient for COVID-19? If they were bringing a patient in from the outside, they are requesting the patient be tested. However, if they are placing within their own facility, what's the guidance on testing those patients in the Swingbed, since it's a different admission?
It's by skilled rules, it's the same admission. It's somebody from the outside. Even though they're in your own hospital, it's a different level of licensure. Remember that your swing beds might as well be the nursing home 10 miles down the road. So if you have a policy from other hospitals that they must be tested, you should have equal policy internally that they should be tested. Now, there is the chance they were tested on your acute level or an emergency room in the 24 hours before they got into acute, then you can make some deviation in that. But you need to follow your policy. And I would recommend just simply because we have, well, I don't know how many times I'm hearing now we're getting 2 or 3 false positives and then a positive, even among our workforce. So we probably have to be very diligent about this for now.
Okay. The next question is to have dedicated staff in critical access hospitals is challenging just due to limited number of employees. Do you have any guidance or suggestions on how to manage that?
Yeah, and I get this a lot, and it is really a valid question, and I don't know the answer. I think this is where your team needs to sit down and use some common sense. We're so wrapped up in 1,000 things coming from Washington or Baltimore every day of our lives right now, and I'm one of them. I'm reading about 170 pages of changes every week. Nobody can keep up with that. So what is the common sense on how we can keep not only the patients safe, but our staff safe and limit exposure? So I think you're going to have to decide, and it's going to have a lot to do with your infection preventionist being involved. So if somebody is coming out of a patient room with COVID, a COVID patient, what are they doing that totally protects that next person from exposure to COVID? And in the process, you are protecting your staff member that's changing equipment and supplies too.
Okay, thank you.
Yep. All right, so we're seeing a lot of differences between skilled nursing, and trust me, it is underreported right now. It is frightening what's going on across the country with skilled facilities, and I'm really surprised that we waited until a week ago Friday to require federal reporting of nursing home COVID cases, and I think it was literally a week ago Friday. So we waited, even though Kirkland in Washington was one of the first alpha sites where we saw what could happen in a skilled facility. The other thing that was very surprising was initially in the March 13th call from CMS, which was the first group call that we had in the country from CMS. At the request of the hospitals, CMS said to nursing homes, you are expected to take admissions. They did say they couldn't enforce it, but they said it at least 4 different times during that call, and then there was a 320 call and a 327 call. They repeated the same information. Those who work in skilled facilities were already very nervous. As you know, it's a very vulnerable population. You can see the data right as of now is 1 out of 3 COVID fatalities is coming from an LTC, long-term care facility. I think that number is, I don't know that it will go up, but the number of deaths that came in long-term care are certainly going to get reported in the next month. They're going to be much higher. Then on 5/20, in the document that I recorded earlier for you, they changed and said, you know what, we really shouldn't be taking outside admissions to skilled facilities. And there's a couple reasons why the nursing homes also shut down. For those of you that were on the hospital side and said, gosh, they're not helping us right now. But one of the requirements almost immediately was somebody coming out of a hospital to a nursing home had to be put in a 14-day isolation. Most nursing homes don't have private rooms, number one, they're cohorted, and number two, they don't have enough rooms, extra rooms sitting around. It's a very high volume required business to cover cost. And then the other piece that needs to be considered is many of them were working on reduced staff. So I have a facility right now that has 0 COVID patients, residents, which I think is phenomenal. But they've lost 17 staff members because they were COVID positive. And that particular facility is requiring their staff to stay out 21 days instead of 14 days just to make sure. And they've kept their residents safe. But when you have 14, 17, 18 staff out for at least 2 weeks, we don't have a lot of extra nurses. We are compounding something that was already going on in this country, which is a nursing shortage. We certainly don't have enough CNAs, and even as we train them quick enough, how do we get them into these settings? So we have a lot of problems going forward, I think, with skilled facilities where we're going to have to put our heads together and figure out the best way to handle that. Swing beds, I think you're seeing sort of a evolution into the next stage for swing beds. They have stepped up, and even in the last conversations with CMS on phone calls, they're beginning to understand swing beds may be a very appropriate sort of place to put these patients that are sicker at a skill level, which is monetarily better for CMS, without infecting potentially long-term care residents. So during this pandemic to date already, we have vent patients that are being put in skilled beds, and swing beds adjusted very quickly. The other advantage you have with swing beds is we have acute trained nurses, and I'm not downing anybody that works as a nurse in long-term care. It's a very hard, comprehensive job. Geriatric training should be required. I mean, it's really extensive, but those nurses have not had to work with vent patients and some of the more complicated, medically complex patients because they have not had those type of admissions to skilled. I do think the length of stay is going to increase because of COVID admissions for swing beds, and remember that is okay. The barrier has been self-inflicted, if you want to put it that way, which is we have often kept swing bed patients under 20 days because it goes into copay at that point. So that's something financially your system is going to have to figure out. And then there will be payment consideration differences between the PPS and critical access swing beds. So either of the settings, it doesn't matter which of those. In swing bed, we need to make sure that we're using the U07.1, that COVID ICD-10 is the primary. For those of you that are doing the MDS, that's in Section 9, that's that primary code, that will increase your payment. They obviously have to be positive, and that has to have been proven, but make sure you're using it. The same with critical access. And then you want to make sure for critical access that you're putting it as the primary code on the claim, the UB04. It's important. So now when we get into payment differences, the PPS have a PDPM rate. It is established across all nursing homes and swing beds that are in the PPS setting. So you have to be running the cost of the patients that you're accepting versus the PDPM. I've seen, and actually more than one governor has quoted $30,000 per stay for the COVID patient on average. I'm having trouble with that. I know swing beds and nursing homes acute can run up 30,000 in no time. Swing beds and nursing homes can certainly run up 30,000 in a very short time, less than a week. And some of these people are staying for a month or more. So you need to run that cost. The importance of MDS accuracy and the chart reflecting everything that had to be done for that COVID patient will be increased per survey. And then you have staffing costs. Like I just said, we have shortages. We have patients that are out because they've staff that's out because they've tested positive. Who's filling in? And so we have increased costs with our staffing as well as some staffing shortages. Critical access, it's going to be important that you understand the cost of all the specialized equipment. Remember, in this setting, all services that are provided to a swing bed patient during a cost swing bed stay must be put on the critical access swing bed claim. So we're talking about vents and other requirements. Make sure you've taken that into account. And then you are reimbursed that way, but your documentation is going to have to show the medical necessity of everything you did. And we're not getting very good 24-hour documentation, so that really needs to improve. And then a reminder for those of you that are not financial, the rate, even though you took higher cost patients, will not be adjusted until the next cost report year. That's where your CFO is going to be real important. Okay, Lisa? All right, So I'm not going to go over this because Lesa just talked about mental health, and I'm going to tell you it's running rampant through the post-acute world. Staff and residents, the biggest issue we have right now with residents that were supposed to be isolated in their room are the dementia patients. So I have some statistics there about the increased number of mental health issues reported, and you can see where Alzheimer's has increased massively just in an 8-year period. But I will talk about dementia with behaviors. It's almost, I had been using the word epidemic until the pandemic set. I mean, it's been epidemic for the last 2 years, the amount of dementia patients. And now they're reporting that 70% of the dementia patients are showing signs of agitation. That we've had to adjust this, where if a dementia patient comes out in the hallway and they want you to hold them in nursing homes, we're doing that, and then we're having to get them back in the room, and then we're having to do the scrub down of the staff member that had that contact. These guys are not going to understand what's going on, so we've had to kind of, again, use some common sense in figuring it out, Lesa. So please consider all of those things as you are working with swing beds to make sure you're admitting patients to your system that you can care for in a swing bed setting. And if there is dementia, they might be a long-term care, better placement. And how are we going to handle that with COVID and non-COVID? I think we have a lot to talk about going forward. The impact on nursing homes, one of the things that's not being described at this point that I'm concerned about is the end-of-life care plans. So if we have this astronomical number of deaths in a long-term care facility, it's important to know what the advanced directives that each of them had individually. They may have asked that they not have more intervention at the end of life, which would prohibit, for instance, the vent and some other things going on. We have a number of people in nursing homes that are in comfort care and or may already be in hospice. I think at some point after we calm down, those numbers are going to have to be separated out within each long-term care facility to figure out which patients were COVID and what we did with them that we could, and which ones were mortality in our mortality rates because of advanced directives or comfort care. The infection and prevention and emergency preparedness are what surveyors are honing in on right now. So you need to make sure your emergency preparedness plan has been checked, whether you are a swing bed and or skilled facility. And remember, if you're swing bed, that falls under your hospital emergency preparedness, maybe with some specifics you have written in because of state regulations for your swing bed. Infection prevention, I have mop heads there. I heard this last week and I would have never thought of it on my own, but surveyors in nursing homes are requiring that if a mop head is used in one room, that it's removed and a new mop head is used before you go in the next room. And just figure out going all the way down a hallway, how many mop heads we're talking about. And that goes for brooms. One of the survey teams said the same thing about buckets. So now we're stopping to clean out the bucket of water that we used in one room, making sure it's sanitized, getting new water and going to the next one. This is just going to go through the whole system, and I can't imagine the number of hours it's going to take at a time when cleanliness is one of the most important things that we can be doing. So please stop and have some conversations about that. In multiple states, we have, the governors have called up National Guard, and they are deep cleaning nursing homes. What has been interesting is how much the staff is noticing that they didn't clean routinely, not because they weren't trying to, but nobody thought about all the vent systems. We didn't think about, we have so many of the light fixtures where we have the clear plastic over, right under the light, and it catches things. National Guard has been cleaning ceilings and vents and all sorts of things. So we can learn from that as we go forward. And then obviously the PPE, we did not factor in nursing homes into the national need for PPE, and they have come up short. They've gotten very creative, and I mean extraordinarily creative, in trying to make their own PPE until that supply could catch up with them. So we've got some planning to do as we go forward. Some best practices I'm going to share real quickly, and you can always email me if you want more detail on any of these. We really do need to develop a baseline care plan that you can use with all your COVID patients. That gives you a starting point. In skilled nursing and in your swing beds, we're supposed to have a baseline care plan in place. within 48 hours. If we have to sit and write everything down where there are some things we could check box, it would save your staff some time. I've seen that being developed. Testing guidance, Lisa's already talked about it. It does vary by state, and I am finding it varies by county. Some of the counties, health departments, are superseding the state because they have a tougher rule. So that's for staff, long-term care residents, and your swing bed patients, as we just discussed with the hospital trying to decide how to handle admissions from their acute to their swing bed. This is a time, and not as we, I hope, are coming into a lull of this, at least for a couple months so we can catch our breath. But those of you that have to complete the MDS, you need to be looking at your quality measures. And there's two sections. One's called BIMS and one's called PHQ-9. That's for depression and cognitive issues. In long-term care, I will bet both of those have been significantly influenced for many of your residents. You're going to have to rescore them, so don't forget that. We have a huge problem that we're beginning to study coming out of skilled nursing with antibiotics. And, you know, we're supposed to not be using antibiotics, but I can tell you from the initial month or two of this, when the physicians didn't know what would work or not work, please know that the antibiotics were thrown at all patients, and we're going to come up with some deficits there where we overused antibiotics. So we're going to be looking at that. We need to make sure, as Lesa already told you, we update our P&P. Social isolation and the dementia patients, I just touched on that, but that is going to be something we're going to have to study heavily. And activities, I've seen some really cool things. The Zoom and the iPad, I think you heard of. I have a nursing home that set up a movie screen for a whole hall, one side of a hall, and invited their family members to sit in lawn chairs, all social distancing, and they showed a movie on the screen that the residents could see through the window and their family could see. So they were on phones with each other, sharing what they were seeing in the movie, and then they moved it around. I have ones that are going around nursing homes outside and doing concerts and that sort of thing. So there's going to be some really creative things with the activities. There is a PPE burn rate calculator, and if you have not gotten that yet from CMS, you might want to download that. That's been helping the nursing homes in particular, but I think that's good for anyone. And then, as I said, there are staff rules that we need to pay attention to. Staff that have moved from facility to facility, we have had to calculate what risk that adds or doesn't add to it. And then, as I said, one of my nursing homes is keeping staff out for 21 days if they're COVID positive. Lesa? All right, these are two that I'm going to send, so I'm not going to spend time on them now. I've already told Becky I will send them afterwards. These are two checklists that CMS has put out in the last 2 or 3 years that are very important. The preparedness list on the left, emergency preparedness, they updated for COVID-19, so I will send that out. The infection prevention was actually done a year or two ago, but those are ones that you should be filling out for your swing bed or for your nursing homes. And the next one, is March 6th, again, with the telehealth. We're seeing a lot of changes. I don't know any better. I'm not pressing it any more than anybody else, but there are certainly reasons to be using it with your skilled patients. The problems we may have are dealing with elderly or dementia patients trying to talk into a phone or to an iPad and comprehend that they're talking to a doctor. So we've got some training to do in there. And the more you can use the same physician or NP will really help that resident if we're doing the telehealth. And then we've got to start shifting our communication from reactive, which is what we've been in for 3 months, to how we're going to do proactive care and treatment. And so policies and so forth. But I do want to tell you there's some history here where we're watching that this may be an evolution into telemedicine for long-term care and skilled facilities. In 2017, CMS had already studied it, and where they were trying to reduce the unnecessary hospitalizations by using telehealth. In 2018, there was a RUSH Act, and RUSH stands for Reducing Unnecessary Senior Hospitalizations, looking at using that with that population. So there has been some language limiting it coming out of Washington in the last 2 weeks. Going forward, I think there will be a heavy emphasis on all facilities trying to use telehealth going forward. So we can spend more time in the next session. Becky, I will go back through telehealth so we can get into more detail because I do know we're on time limits. Lisa, the next slide. And this is just remember your discharge appropriateness. We have patients that are going to post-acute settings. Very few people are going, that are elderly anyway, are going home directly from a hospital. So we need to be checking for things like our cognitive status. I will go back, and I should probably add to this, the depression and anxiety are off the scale. The need for meds. We already have an elderly population that's not taking meds appropriately. They either can't afford them or they're on 10 meds and trying to remember what color pill they take at what time of the day. We've got a huge problem there. With this additional stress, I really believe we're going to see some med issues hit our ED here if this continues for the next couple of months. So we're looking at how they can stay safe 24 hours. Is the family really going to be with them? So all those things that your case managers and discharge planners already have identified are heightened during a pandemic. So right now we have to heighten our alerts on how we're going to take care of these patients safely. And then I hope during the summer we have time to take a deep breath. We need to figure out how we're going to rearrange our discharge process. And that may mean making the calls, setting up, as Lesa talked about, setting up appointments and making sure they're not having to wait for them long time periods. And I do think, and I've said this actually for years, that swing beds need to call patients at least 48 hours or within 48 hours after discharge, and probably weekly up to the 30 days, trying to keep down the readmissions, whether you're critical access or not. All right. I have some lists here of compassionate care information. There's really good. One of them has a toolkit. All of them have very good information that may help those of you that have long-term care in your consideration. At least if you go to the next one. I want to say, going forward, it's time we catch up with ourselves. This is the 13th pandemic since 2000. This is not a new process for us. And some of these, and this is not even including the flu, which we now know hits us seriously. 2017, 2018, we had 61,000 deaths from flu. They thought this was going to be a milder flu season. In 2018, 2019, they were estimating 34,000. I don't know how COVID and flu are going to mix. I don't know anyone that does. And I left this chart up here. I did it for an earlier presentation because this was looking at the end of April. So basically a month ago, we were at 50,000 deaths, and we're rolling up to 100,000 now. They don't seem to think that number is going to go down during June, just because there's a delay of time where we get these numbers. So this is very, very serious that we think now, please, if you take nothing else out of today, this isn't going to pass. Even if we get where we can control COVID, you look at this history, there'll be something else that's coming down the path. We've got to take each of our breaks during these things and find a new way of addressing multiple areas where we've had to scramble during this pandemic. And I think that's the big message for today. And I have some resources for you. And Becky, I'm going to stop talking. That's about as fast as I can talk, and I'm from New England, so.
Well, thank you, Lesa and Kerry, so much for today. I know there will be questions after the session closes here, so email those to me and we'll facilitate getting an answer back to you. And they will also be sharing on our next FQNC meeting in July. And so look for more and let us know what other topics you would like covered during that next session. And looking forward to working with the Swingbed teams at our regional meetings coming up in June. If you want to attend those sessions and have not received an invitation, please send an email to me, Becky Royer, and I will get an invitation to you. So stay safe, everyone, and thank you so much. I hope you found the information today very helpful. Goodbye, all.